Government TD Medical College. He is the Executive Director of K Soto as well. Sir is an exemplary academician as well as a clinician, and he has initiated and implemented the disease donor program in Kerala with his mentor, late Professor Ramdas Pisharodi. He has been widely cited and has numerous publications to his name, and he has his keen areas of interest include disease donor organ transplant, diabetic kidney disease, and precision medicine in solid organ transplant. I hand over the stage to you, sir, for your presentation.
Thanks for the introduction. I would thank Professor Vinoy and the nephrology team of CMC Vellore for inviting me. Straight away to the topic. There will be some overlap between Professor Vinoy's talk and me, because to understand a treatment, you should understand pathophysiology very clearly. And as Dr. Vinoy said, you have to practice medicine wisely and honestly. As Dr. Joseph said, you don't prescribe a medicine which doesn't have any value addition to the alteration of the pathophysiology. And my obesity is not because of I eating more, because of my gut microbiome. Please pardon me for that obesity. So putting Dr. Vinoy's the entire 30 minutes presentation to one sentence, it is a multiple pathophysiological mechanisms operating simultaneously or sequentially. We don't know which one first, hen or egg. It's difficult to understand. Resulting in a clinical syndrome characterized by combined heart and kidney function. So as a resident, you should understand there is a problem with the heart and kidney. There are a lot of pathophysiological mechanism acting on both heart and kidney. So we need to address the heart and as well as the kidney. So we'll go through few cases which characteristically explain our syndromes. This is all real life cases. This patient is currently admitted in Medical College Alleppey. It's a 73-year-old female, type 2 diabetes, hypertension, 5 years. They had a previous creatinine of 1.6, but it is not clear whether it is CKD or not. She was admitted with CAD, acute coronary syndrome with extensive enteral MI. We did lyse her, and she developed hypotension, cardiogenic shock, echo showed severe LV dysfunction with the EF of 20%. These are the creatinine. These are the real life values of on first, he was actually at 1.1. That is why I doubt this 1.6 value. He had a baseline of normal renal function. And this is on 5th day value. This is 4.4. And initially, he had an oliguric. Then this oliguria picked up and she recovered. We didn't dialyze her. We just managed conservatively. So what is happening? So here is a near normal heart having an acute dysfunction, causing a disease start. Here the kidney had several stress which causing kidney to decompensate. So you have a small management window to support kidney as well as heart. What we did. So this is again reiterating, there is hemodynamic changes. This is very important. There is relative decrease in cardiac output, arterial underfilling. There is sympathetic overactivation. You have a ischemic vessels in the tubules, decreased perfusion pressure, AKI. So you need to address this overactivation, and also you need to decongest the kidney because of the extensive congestion. And there is always any acute stress in the body will have an inflammatory overload, and there will be an oxidative stress. So we need to address all these things. This is again a new terminology in the background of cardiorenal syndrome. It's a forward failure and backward failure. What is this forward failure? Because of the reduced cardiac output. And what is backward failure? Because of the renal congestion happening inside the kidney. So we need to address this forward failure and backward failure. What are the drugs we have? We have angiotensin receptor blockers. We have sacubitril. You all know about this ANIS. We have SGLT2 and this mineral corticosteroid receptor antagonist. Now it is NSMRAs. And we have loop diuretics which reduce the congestion. So these are the pillars of therapy. When you put what, we'll be discussing subsequently. So what is this ANI? ANI is a neprilysin inhibitor. What is neprilysin? It's a zinc endopeptidase, which break down all these vasodilatory peptides. So what does this vasodilatory peptides do? It have a lot of beneficial effects. You have vasodilatation, natriuresis. So it's a very protective thing. So if you elevate the levels of vasodilatory peptide by inhibiting this neprilysin, probably you'll have some effect on the heart. So what is this diuretics SGLT2 do? SGLT2 have an excellent sodium diuresis because it acts on the proximal convoluted tubule. It have protective mechanisms in renal fibrosis, all pleiotropic effect, apart from its capacity to reduce sodium reabsorption in the proximal tubule. So it have a reduction in renal tubular inflammatory response. You have a reduction in oxidative stress. With all these important pleiotropic function, what these guideline people said, they said you have a magic molecule in SGLT2, in heart failure, in type 2 diabetes, in chronic kidney disease, all have class 1 recommendation. See this? So now most of the even American Academy of Clinical Endocrinology ADA guideline has placed SGLT2 inhibitor over metformin as a first-line therapy in all patients with diabetes. So this is a drug which probably the best innovative drug in this decade. So if we come back to the case, so you all think about this case. This is a nephrology consultation in an ICU. So I asked my PG, did you start her on SGLT2? She asked me, do we have any evidence for that? Or is it right time to start a SGLT2 or an ARNI in this acute decompensed heart failure? There is a trial which looked at, it is called Dictate Heart Failure Trial, which looked at decompensed acute heart failure where EMBA is used. And what DAPA is used, and what they found, there is time to completing IV diuretic therapy and time to hospital discharge, DAPA safe across all diabetic and cardiorenal in-hospital outcome. But they waited till that acute decompensation phase is over, patient stabilized, then only started dapagliflozin. So there is a role, not at the ICU, probably in the semi-ICU or in the ward, you can initiate before discharge. So this is a Dictate HF trial. Please go and read because it is very important when to initiate SGLT2 inhibitor in an acute setting. Whether can we start ARNI in ADHF? Yes, definitely yes. There is a scope for, there's two very established trials which looked into the acute decompensed heart failure, Pioneer HF and Transition. They both found that it reduced hospitalized patient with the acute HF before discharge so that patient have a better outcome. So there is evidence for SGLT2 as well as ARNI in acute decompensed state, but only after stabilizing the heart failure and the kidney worsening status. This is a transition study. Please go and read through this. This has very important finding of stabilizing the renal dysfunction and cardiac dysfunction, acute cardiorenal syndrome at a CRS type 1. This is another case. This is a 47-year-old male, no comorbidities, presented with acute onset breathlessness, axillary hypertension. His presenting creatinine was 10 milligram and blood urea was 230, HD initiated by right IJV because he was very breathless. In spite of alternate day hemodialysis, he was still breathless. We did a CT thorax, no pulmonary, we thought of it as anti-GBM syndrome, but it was not anti-GBM syndrome. Echo showed moderate LV dysfunction at the outset itself, 30% of EF. Renal biopsy were thrombotic microangiopathy and genetics showed CFHR5 mutation. Now he is currently on MHT thrice weekly, waiting for a disease donor transplant. So what has happened? He had an acute kidney injury due to a glomerular disease. And what has happened? There is a decreased GFR, increased sodium and water retention, hypertension, volume expansion. He came with the acute volume overload, and we need to do dialysis. So he had an acute decompensation, acute heart failure. This is all come together because of your acute kidney injury. So kidney causing, this is a renocardiac syndrome. So how do you manage type 3 CRS? Anyway, you have to put him on optimal dose of diuretic. You need to identify the cause of underlying AKI. You need to put him on good hemodynamic support. If he's high BP, you need to reduce his BP. If it's low BP, you have to support BP. And prompt initiation of renal replacement therapy in the form of hemodialysis or CRRT, whichever is appropriate. So here, can we initiate RNA or SGLT2 at the hospital setting? We initiate RNA not during the acute phase. After some time, that is after 1 month, when volume overload and all is established, then he was on thrice weekly hemodialysis, euvolemic, we initiate him on RNA. What happened? Hospitalization episodes reduces now 6 months since. He has no hospitalization, dyspnea is reduced. Do we have any evidence for SGLT2 or RNA in ESRD stage 5? There is an ongoing trial called DAPA-HD, it's not completed yet, which is looking at SGLT2 inhibitors in patients with hemodialysis. And another trial also is going on SR-HDF to study RNA in MHD. So probably evidence will come for favorable SGLT2 as well as RNA in hemodialysis patient. So this is another case, the case 3, the 64-year-old female with history of type 2 diabetes, hypertension, dyslipidemia for 4 years, presented with history of chest discomfort, underwent a CAG on September 2021. CAG, severe triple vessel disease. They did a PCI to proximal RCA and optimized on medical management. Even though she had a diffuse, other vessels also is diseased, but they could manage only RCA with stenting. Echo showed concentric LVH, mild TR, LV dysfunction. Recent echo, that is November 2024, she had a dilated cardiomyopathy, probably ischemic, moderate LV dysfunction, stage 2 diastolic dysfunction, moderate MRTR. What is happening here? Here, because of his chronic atherosclerotic vascular disease, his kidney is failing. This is the values. 1.2, 1.7, 3.8. This is under regular follow-up from us, but at front of your eyes, your kidneys are deteriorating. So what is happening? You have basically this here there is highly activated RAS. So optimizing ARB is the crucial thing in managing this type of patients. But whenever we see these patients, they will probably on a very low dose of angiotensin receptor blockers. We never optimize the dose because of scaring of renal failure worsening. But please optimize ARB unless and until contraindicated by hyperkalemia. Otherwise, there is no contraindication for ARB. So all patients should have an optimal RAS blockade. All these evidences are on and above the optimal RAS blockade. Whatever SGLT2 benefits, whatever other drugs are benefiting, only on optimal RAS blockade. And you have inflammation and oxidative stress. This is leading to chronic. And she had a very bad POVD also. So she have a all problem of a extensive atherosclerotic vascular disease. So once this type of patient comes to you with a creatinine of 1.2 in 4 years back, now he is in end-stage renal disease. So we have to intervene appropriately and promptly. So SGLT or RNA or sequential. I would always go for SGLT2. The problem is most of our females have a recurrent episodes of UTI when you start on SGLT2. But it is justifiable to start on SGLT2, wait for some time, and if cardiac symptoms is not improving, RNA would be a sequential next step. So always think of these two drugs whenever you manage a patient with heart and kidney dysfunction. So is there any evidence for SGLT2 in this type of? Definitely yes. You have DAPA-HF trial, you have DELIVER trial. All these things have shown there is a decrease in all-cause mortality and reduced heart failure symptoms. So there is enough and more evidence for SGLT2 in these type of patients. Is there any evidence for RNA for these patients? Definitely yes. You have two classical landmark trial, Paradigm HF and Paragon HF, all showed their benefits irrespective of background therapy and previous coronary revascularization. So these patients should have put on RNA and SGLT2 when I see this patient 2021. But I didn't have the guts to do that, and now the patient went on to severe renal dysfunction. Probably I would have given some Loban also that time. I don't know. So this is sotagliflozin. This is the first dual SGLT2 and SGLT2 and 1 inhibitor which has got FDA approval. I don't know why FDA has got given accelerated approval, because the trial was interrupted because of lack of funding. And even then, the SGA, what's given approval for the therapy. And it has gone very good support for benefits as SGLT2. So now it has shown that consistently decreased hospitalization and urgent visits for heart failure. So it has given approval to probably will come soon to the Indian market also. This also you should be very clear when you initiate therapy, because I had a male patient, type 2 diabetes, not a renal failure, coming with severe candida infection of the penis because of SGLT2. And he said, my doctor didn't tell me about the chance of occurring penile candida infection when I start on SGLT2. So he was very annoyed about the doctor. So whenever you prescribe SGLT2, please tell that your what you call genitourinary hygiene is very important. So it is beneficial to continue on SGLT2 rather than stopping because of UTI. And slight increased risk of euglycemic ketoacidosis and concerns about lower limb amputations. This is also very important. Please look at the nails, nail beds, nail infections, web space infections when you continue patient on SGLT2. But what are the risks? There's a lot of risks, lot of benefits. HbA1c, weight loss, blood pressure, albuminuria, CVCD risk. So here is a drug which have lot of benefits in your patient, but you not describing this to the patient, and they stopping this because of small genitourinary infection and post hypertension. And also you should tell them to drink a lot of water, because we as a nephrologist have a tendency to tell them don't drink much water because it is causing edema, because it's a very overt symptom for you. But if patient is euvolemic and they don't have any renal failure, there is no tendency to have water retention, please tell them to drink more water. Because ARB and SGLT2 inhibitor work very well in a euvolemic state. Don't make him hypovolemic. That is a very important message you have to take home. So here, in this patient, what should I have done? I should have started him on ARB, optimize, and for better sugar control, I should have started him on GLP-1 or a non-steroidal MRA to prevent proteinuria. So now, this New et al. Has written a very interesting article, whether we go by guideline and wait for 6 to 12 months to optimize all these available therapies, or you go with a rapid sequence approach. This is an article worth reading, because I also feel that the last thing is better, because by the time you wait for 1 year or so, and all organs are gone, and the patient will be ready for your dialysis. So this is a case 4. This is actually a young girl at 14 years of age, diagnosed with IgA nephropathy. It's a biopsy proven. She is now on MHD. After 4 years of diagnosis of worsening renal function, his creatinine was 1.4. Progressed to ESRD in 2 years' time after that. Echo done at we usually have a baseline echo at the time of initiation of dialysis. So it showed moderate LV dysfunction and grade 2 LV diastolic dysfunction. And my resident promptly put him on ARNI, put her on ARNI. And 2 years after, there is not much of reduction in ejection fraction. That is almost stabilized ejection fraction. So I would appreciate my resident who had the courage to put him on ARNI in the case of end-stage renal disease. But they were closely monitoring his potassium, and there was no hyperkalemic episode. So don't fear about hyperkalemia in an optimally dialyzed patient, because ARNI is having a lot of benefits for the heart. So this is already described by Vinay. A lot of things which as the CKD progresses, a lot of harm things happen to the heart. So you need to prevent the progression of kidney disease as well as the protect heart for not going in failure. So this is our own study from Medical College Trivandrum, headed by Dr. Jacob George, who was a PI for this study. But we did very less number of patients, but we did for CKD for stage 5, we had 22 patients, and CKD stage 4. See, the decrease in hospitalization is almost 94%. That is 18 patients included. None of them had a hospitalization history because of NIHA or worsening breathlessness. And NT-proBNP is, as in international studies, we showed that in 5D patients, reduction is not that significant, but in CKD4, the reduction is very significant. And hyperkalemia, only one patient, because if the patient is optimally dialyzed, you will not get hyperkalemia, and if they are good on dietary restrictions. So decrease in NAHE is almost 100%. That is, patient breathlessness symptoms just disappeared by initiation of sacubitril valsartan. So this is an Indian real-world experience of starting ARNI in HD patients. After that, there are a lot of studies which is looking at ARNI in hemodialysis patient. So what happened to the NT-proBNP after ARNI initiation? See, a significant reduction in NT-proBNP after ARNI initiation. This is not from our study. This is the last case. This is 20 years of diabetes, CAD in 2017, vertebro-basilar stroke in 2020, ACS stroke in 2021, very worse atherosclerotic vascular disease, and CS creatinine now, it's 4 milligram. So this patient, which is I am seeing for last 10 years, I think more than 15 years, I also given some sodium bicarbonate and probiotic and some drugs, but I should have put him on an aggressive DAPA, SGLT2, ARB, otherwise she would not have reached this stage. So this is, all these illustrations are from the Rongo et al., which has described pathophysiology of cardiorenal syndrome. So this is systemic diseases causing heart disease. So this is one of the most important slides you should take home to the, this is a pooled analysis of canvas and credence. See this, before CKD progression and after CKD progression, what is happening to the MACE events. See how many times it has been increasing. And again, here it is in CKD progression before and after CV events. See, before heart failure and after heart failure. So these two organs actually complementing each other. When they start losing their function, it worsens the other organ. So you have to be aggressive on preventing worsening of your CKD and also preventing worsening of your heart failure. So this is also a very good journal which you can type like this, bidirectional relationship between kidney disease progression and CVD when in type 2 diabetes. You get a very interesting article on how these two diseases complement each other or worsen each other. This is, I recently found out an interesting article on pathophysiological based therapy for cardiorenal syndrome. This DRIP2P2S is, DRIP2 is decongestive or dilators, reduce fluid overload, congestion, improve blood flow, reduce vascular resistance. You have loop diuretics and splenic nerve blockades. Renal replacement is R. You have already, we've given that patient inotropes. This is for enhancing the cardiac contractility. In first case, we gave dobutamine and interstitial fluid management. And they have now found out some compressive devices which compresses your interstitial fluid into the intravascular system. And you have pullers and pushers. This is also devices which pull the blood from heart to the periphery and also reduce the venous congestion. And pushers enhance arterial flow and renal perfusion. And as you all know, the cardiologists have a habit of putting devices wherever they find any hole. So these are the devices for cardiorenal syndrome. I couldn't understand the mechanisms at all, but they are putting all devices everywhere they see a vessel. So these are the devices in cardiorenal syndrome. They have, but it's all based on the pathophysiology. When you have an increase in afterload, they put afterload preventing device. When you have a preload, they put preventing preload. And even they have put stent in the thoracic duct which pumps lymphatic flow so the interstitial edema is reduced. So this is how they are putting, we are just simply sitting and watching the creatinine. So please put some devices somewhere and reduce symptom. So this is a summary. SGLT2 inhibitor restores the tubular feedback leading to vasoconstriction. And all you know is it reduces hyperfiltration and delays the progression of CKD. This is a proven truth. As daylight and sun, as night and moon, SGLT2 have benefit in kidney disease, and ARNI can be prescribed in non-dialysis patients, CKD and HF. In dialysis patient, you can wait a bit more, then the results will come. So we have ample and strong evidence for both these drugs. So please use liberally and stop using probiotics. So thanks from the bottom of my heart to the opportunity. This patient, I would like to describe, the heart failure, got a cardiac transplant from the deceased donor from Kerala. And he was a policeman. He was in ICU for more than 6 months on dobutamine and pressors and all. This boy is the son of the donor. After 1 year of the transplant, the doctors called them and the mother was standing beside him. He is actually hearing the heartbeat of his father. So this is what a transplant can do, transplant try, and he got a promotion from an ASI to SI. He is in very happy mood. So cardiac transplant has a very important role in managing cardiorenal syndrome. And so a million salutes to all donors. Please encourage deceased donor program as young nephrologists. Thanks for the patient listening.
Thank you, sir, for your insightful talk on therapeutic advances in cardiorenal syndrome. This talk has surely provided us with a deeper understanding of these groundbreaking therapies that we have now and their potential to transform patient care in these challenging areas. We have a few questions from the audience.
Yeah.
The first question, can SGLT2 inhibitors be given in patients with EGFR of less than 20 ml per minute? And we see a lot of cases with severe hyperkalemia when we start patients of ARNI. So how frequently should we monitor for these side effects?
Hyperkalemia or on ARNI?
Yes, sir.
Yeah. Hyperkalemia or ARNI is not that common, but you can get. But the problem with South Indian diet is we eat lot of coconut chutney. Coconut is the potassium storehouse. So whenever you prescribe ARNI, you just tell them you avoid chamandi from your diet. And otherwise, you'll definitely come with a hyperkalemia. So dietary restriction is very important. And when you initiate ARNI, at least 5 days later, you check a potassium, and then 3 weeks later. If there is no hyperkalemia, you can straight away ask them to continue. Otherwise, diet is the most important thing when you prescribe potassium. For example, I am part of a Finerenone trial. One lady with a creatinine of 2.1, she is not able to continue on Finerenone because of hyperkalemia. When I explored, she used tengapal curry, the coconut milk. With most of the fish curries, she uses with the coconut milk. Then finally we identified that and stopped it. Now, even though it's higher because she's so obsessed with coconut, probably she'll not get rid of coconut. It's always at around 5.5. So we couldn't start because 4.8 is the cutoff for Finerenone to continue. Then.
So the next question. Is there any difference in management approach in patients with heart failure with reduced ejection fraction as compared to patients with heart failure with preserved ejection fraction?
Yeah.
And is there any benefit of giving SGLT2 inhibitors and ARNI in patients who have heart failure with a preserved ejection fraction?
It's already this paradigm and paragon looked at. One is on reduced ejection fraction and one is on preserved ejection fraction. It's already shown constant benefit, but benefit is more with patients with reduced ejection fraction rather than preserved ejection fraction. And you can give with preserved. Not much of evidence is there, but you can give. There is considerable benefit in SGLT2 ARNI in clinical practice when you combine. A lot of my patients are on this combination with preserved ejection fraction.
So one last question. There's a clinical case of a 10-year-old boy with a heart failure with reduced ejection fraction 30% with CKD stage 5. They tried treatment with ARB diuretics, but there was no treatment so far. So no improvement so far. So they want to know, is there a role of hydralazine in this patient, sir? Yeah,
ARNI can be tried actually. ARNI can be tried with a reduced dose. You can, ARNI is a scored tablet. You can give half and try. After some time, you can titrate it. ARNI is definitely beneficial for it. Thanks for the
Thank you,
questions.
sir.